Welcome to the deep dive. Today we're jumping into something that I think a lot of people have, well, some pretty strong feelings about.
I think that's putting it mildly. It's a topic that's surrounded by anecdotes and horror stories.
Right, we're talking about the management of third molars, or as pretty much everyone knows them, wisdom teeth.
Our mission today is really to move past those stories your friend told you. We want to get straight to the clinical rationale, the actual guidelines that dentists use to decide when and how these teeth need to be managed.
Okay, so let's start with the absolute basics. What are wisdom teeth and why are they such a common problem?
They're simply the last set of molars to show up, usually between the ages of about 18 and 25. And the problem is, well, it's all about geography.
Geography.
Our modern jaws just don't have the space. They're at the very back of the line, and if there's no room, they can't erupt properly. They get stuck, or as we say, impacted.
And that's the key word, impacted. But here's the critical hook we want you to hang on to right from the start. The reason for removing them isn't just about fixing the pain you might be in right now. It's often a calculated preventative strike.
It absolutely is. And it's often to protect a much more important tooth, the one sitting right in front of it.
So if a wisdom tooth is impacted, or maybe just partially poking through, it predictably becomes a problem area.
A magnet for disease. That's how we see it. You get localized pain, infections, ulcers where it rubs against your cheek.
Yeah.
Sometimes even more serious things like pathological cysts.
That's the immediate damage. But you mentioned the bigger threat, this idea of secondary damage.
Yes, and this is really the clinical aha moment for patients. We view an impacted wisdom tooth as a localized disease reservoir.
A disease reservoir. That sounds serious.
It is. That little flap of gum over a partially erupted tooth is impossible to keep clean. It just traps food, it harbors bacteria, and that whole mess can then transmit decayed dental caries directly to the tooth in front of it.
The second molar.
Exactly. Your main chewing workhorse back there. So the rationale for extraction shifts. It's not just about the wisdom tooth anymore.
It's a necessary sacrifice. You're giving up a tooth that might never be functional anyway to save one that's absolutely vital.
That's the long-term view.
Yep.
Preventative maintenance for your whole mouth.
Okay, before we move on, we have to address the classic myth, the big fear, especially for teenagers. Do wisdom teeth make your front teeth crooked?
The crowding myth. We hear this all the time. But the studies on this are pretty clear. They play a very, very minor role, if any.
So getting them out won't magically straighten your smile?
No. Crowding is much more about skeletal factors, the size and shape of your jaw. It's not about some mild pressure from the back. The reason for removal is almost always about pathology, not cosmetics.
Let's focus on the most common pathology then. You hear the term thrown around a lot, pericoronitis.
Pericoronitis. It's just the acute inflammation of that gum tissue sitting over a partially erupted wisdom tooth.
Because you can't clean it.
You can't. So it swells, it gets painful, it can even harbor pus. Now, a single episode, we can sometimes manage that with cleaning and maybe some antibiotics.
But what if it keeps happening?
That's the key. The clinical guidelines are explicit. Recurrent episodes of pericoronitis are a strong, clear justification for getting the tooth out. If it keeps getting infected, it has to go.
So once a problem is flagged, you move to diagnostics. And the main tool here is a full mouth x-ray, the OPG. What is that exactly?
OPG stands for orthopantomogram. It gives us a big panoramic view of everything, but it's so much more than just a picture.
What do you mean?
It's fundamentally a risk mitigation device. It's a surgical map. We use it to assess three absolutely critical things before we even think about touching the tooth.
Okay, what are those three things?
First, the tooth's exact position. Is it sideways? Angled? And what do the roots look like? Are they complex? Second, we look at the bone density around it.
Which tells you how hard it's going to be to get out.
Precisely. And third, and this is the most critical part for avoiding major complications, we map the proximity of the roots to the nerves.
So the x-ray is literally mapping the potential for permanent damage.
Yes. We're looking at the path of the mandibular nerve, which supplies feeling to your lower lip and chin. If those roots are tangled up with that nerve, it changes everything.
So the decision to remove is based on this risk-benefit analysis you can see on the screen.
Exactly. Is it causing problems now, or is it at a high risk of causing them in the future? It all comes from that image.
And if the decision is preventative, there seems to be a very specific recommendation on timing, a critical age window.
Oh, absolutely. The data is overwhelming on this. High-risk wisdom teeth are best removed when the patient is younger, ideally right around age 25.
Why age 25 specifically?
It's all procedural and biological. At that age, the roots aren't fully formed yet. They might still be kind of tapered. and the bone is just softer, more elastic.
So it's an easier surgery, less drilling, less trauma.
An easier surgery, a faster recovery. If you wait until you're, say, 30, those roots are fully mature, maybe hooked, and the bone is dense and fused around them. That makes the procedure much more complex.
And it increases the risk of those complications, like nerve damage.
By a significant amount. So
Yeah.
early removal is all about minimizing lifetime risk.
But what about the ones that are asymptomatic and low risk? The advice is just to observe them, but how do you actually keep them clean back there?
It's a huge challenge.
Yeah.
And it requires specific techniques. You can't just brush normally. First, you probably need a toothbrush with a much smaller head to even get back there.
Okay.
Second, and this sounds totally counterintuitive, when you brush the cheek side of those teeth, you need to keep your mouth partially closed.
Closed, not open wide.
Right. When you open wide, your cheek muscles tighten and you lose all the space. If you relax your jaw and close down a bit, you create slack in the cheek.
And that lets the brush head actually reach the tooth.
It gives you the space you need. It's a crucial little trick. And while antibacterial mouthwash can help with a flare-up,
It's not a long-term solution.
not at all. The guidelines are clear. It's no substitute for mechanical brushing. It doesn't remove the food that's trapped.
Okay, so extraction is the final decision. The procedure itself, who does it and where?
Well, there's flexibility. A straightforward one can be done by a general dentist. More complex cases, they get referred to an oral surgeon or a maxillofacial surgeon. And that can happen in a clinic or, for the most difficult ones, in a hospital.
And the setting is often decided by the type of anesthesia needed. Let's walk through those options.
Sure. The most basic is local anesthetic, or LA, just the numbing injection for simple cases.
Then you have the next step up, conscious sedation.
Right. Happy gas or IV sedation. The goal there is to really reduce anxiety. You're still awake, you can respond, but you're very relaxed and you won't feel pain.
And the final option is general anesthesia, GA, where you're completely asleep. What pushes a case into needing GA?
It's usually a combination of things. First, surgical severity. If we're taking out 4 deeply impacted teeth at once, for example. Second, patient factors. Some medical conditions or a really severe gag reflex can make it necessary.
And what about fear?
That's the third, and a very common reason. Extreme dentophobia, a level of fear so severe that the patient simply can't cooperate safely, even with sedation. In that case, GA is the safest and most humane option.
Before any of this happens, though, there's the mandatory talk about risks. Informed consent. Why so strict for such a common procedure?
Because it is surgery. And while complications are rare, they can be severe. The biggest one we map for is neuropathic risk, nerve damage.
Back to the OPG, the X-ray map.
Exactly. We're looking for that relationship between the root and the nerve. If damage does occur, the patient can experience numbness or pins and needles feeling.
Is that permanent?
Usually it's temporary, it resolves.
Yeah.
But we have to disclose the small risk of long-term or even permanent altered sensation, which is called paresthesia. It's a quality of life issue.
What other healing complications are on that list?
The most famous one, of course, is dry socket or alveolar osteitis. That's when the blood clot that's supposed to form in the socket gets dislodged. It is extremely painful.
I've heard stories.
They're not exaggerated. We also have to disclose structural risks. Things like accidentally damaging the tooth in front, or for upper wisdom teeth, creating an opening into the sinus. These are the high stakes.
So the surgery's over, recovery begins. There's the general advice, take it easy, no contact sports. But there's one very specific, hard and fast rule tied to anesthesia.
There is. It's a legal regulatory safety rule. If you have a general anesthetic, a GA, you are legally prohibited from driving any vehicle for 48 hours.
48 hours, non-negotiable.
The effects on your coordination and judgment are just too significant. You have to plan for a ride.
That's incredibly specific. And yet, there's a paradox here. The clinical guidelines are very detailed about that, but they seem to go silent on other really important parts of recovery.
Yes, this is a key insight. The public-facing documents deliberately do not give specific one-size-fits-all instructions for 3 things: your diet, how to clean the site, and exactly how to manage your pain.
That seems weird. Why leave out the most practical advice?
It's a necessary delegation. It's about customization and, frankly, liability. Those instructions have to be personalized by the person who did the surgery.
So my diet instructions would be different from someone else's.
Completely. A simple extraction might mean you're on soft foods for a day. A complex bony impaction might mean liquids only for 48 hours, then a very slow progression. It depends entirely on the surgical trauma.
And what about cleaning? How specific does that get?
Vary. For a simple case, maybe just gentle saltwater rinses. But for a deep socket, we might give you a special syringe to gently flush it out after a couple of days. You can't put that level of nuance in a general pamphlet.
Same goes for pain management, I assume.
Of course. The type and strength of the pain relief depends entirely on the anticipated pain level and your own medical history. So the guidelines leave it to the treating dentist to deliver those critical, individualized protocols directly.
Which means the complexity of your surgery dictates how long you'll need off work and also how specific your post-op instructions are going to be.
At the end of the day, it's a high-anxiety procedure for many people. The fear of dry socket, the worry about nerve damage, it's all very real.
And that clinical reality creates a demand for a certain type of care, doesn't it? For providers who can manage not just the tooth, but the patient's fear.
Absolutely. This is where we see practices that brand themselves around a promise of a gentle or pleasant experience. They are strategically targeting that anxiety.
So how do you actually operationalize a promise like gentle? What does that look like in practice?
It's about turning fear into trust. And a huge part of that is transparency.
Explaining everything.
Everything. Explaining the risks in a way that's easy to understand, not just listing them off. And being totally upfront about costs and payment options, which removes another layer of anxiety.
You're tackling the fear of the procedure and the fear of the bill at the same time.
Exactly. Then you add operational things, like for busy professionals who put off treatment, a practice that has extended hours, open late on a weekday, open on a Saturday, removes a major barrier to getting care.
So gentle is about more than just the technique in the chair. It's the whole system.
It's a whole system. And you see it in the feedback. When patients with huge fear say they had a good experience with a complex procedure, that's when you know the model is working. The emotional promise becomes an operational reality. So to wrap it all up, managing wisdom teeth is not some random event. It's systematic. It's rooted in risk mapping with that OPG X-ray, and it often has this clear prophylactic mandate, get it done around age 25 to prevent much bigger problems down the road.
And for you listening, the real takeaway is that duality of care. You've got the big universal rules, no sports, and that absolute 48-hour driving ban after a GA. But those exist alongside the essential, highly personalized instructions for your diet, your cleaning, your pain management. Those have to come directly from your surgeon.
The guidelines transform a rite of passage into a high-stakes surgical procedure that needs careful planning.
Which leaves us with our final provocative thought for you to chew on. If you still have your asymptomatic wisdom teeth, think about that age 25 mandate. How does this clinical preference for early intervention challenge that old mindset of, if it ain't broke, don't fix it?
Especially when the risk is clearly mapped and the solution is just demonstrably easier, safer, and faster when you're younger.
Something to think about. Thanks for diving depth with us. We'll see you next time.